Hey, you guys missed me, didn't you? I'm back. It's Miss Mary RN, and I have at special request a video about the autonomic nervous system and medications associated with it. So let's get started. Let me share my screen. And let's get this straightened out. I'm going to pause for 1 minute. And here's the one we want. All right, let's cut right to the chase. Move this out of the way and make this bigger. And here we are. The autonomic nervous system and medications, everything you always wanted to know, but nobody could explain it the way I can, right? Okay. So the autonomic nervous system, just think automatic. That's the part of your nervous system that's involuntary. So in other words, how do you breathe? You don't have to think about breathing. It's your autonomic nervous system, right? So here's a little diagram to kind of help you better understand what it is. So you've got your central nervous system, okay, which consists of your brain and then your spinal cord. And then your central nervous system has an afferent and an efferent division, okay? So what that means is the afferent is where you see things, you smell things, you hear things, the stimuli goes to the brain. And then the efferent division is the part that makes you move. When you think to yourself, I want to stand up, and you stand up. That's the efferent side. Okay. And so here we've got your peripheral nervous system, arms, legs, torso, right? The efferent division. And then if we break it down a little bit more, we've got the autonomic nervous system, which is the involuntary side. The somatic side is the voluntary side. That's your motor neurons, that you walking and talking and moving, right? But the autonomic side has your sympathetic and your parasympathetic. Remember fight or flight? You do. Okay. So the sympathetic and the parasympathetic nervous systems have to do with the release of different neurotransmitters and what kind of a state they put your body in. So let's break it down a little bit more. So the sympathetic nervous system, we'll start there. It has these kinds of effects on your body, increases your heart rate, right? Increases the pumping of your heart, dilates the bronchi in your lungs for increased airflow. It constricts blood vessels in certain areas, but redirects the blood vessel and the blood flow to certain vital organs and to your legs. Think about fight or flight. When the sympathetic nervous system is activated, it's getting your body prepared to run or fight. Okay. If you just ate something and all of a sudden you sense that you're in danger or there's anxiety, your sympathetic nervous system will kind of shut down your digestive system. Nope, don't digest. We need all that blood flow to the arms and the legs to fight or run. And also the pupils will get dilated. So this way you can see better, lets you run faster, hit harder, and see better. So you're either going to fight or you're going to flee from whoever's attacking you. Okay. The parasympathetic nervous system, that's the relax, right? After the sympathetic, parasympathetic is what relaxes you, slows down your heart rate, constricts the bronchi, right? Reducing your airflow, relaxes your blood vessels, sends blood back to your digestive organs so that you can start digesting your food. And it constricts your pupils. It's the relaxation mode where you're calm, chill, okay? And again, here's a nice little chart that kind of explains the sympathetic versus parasympathetic. With the sympathetic, you're on high alert. Pupils are dilated. You don't have much saliva. Okay. Your mouth is dry. Heart rate accelerates. Bronchi is dilated so you can breathe. Okay. It inhibits peristalsis. So your gastrointestinal processes. It'll automatically tell your liver to convert glycogen to glucose. So this way you've got sugar in your bloodstream that you can use readily for whatever energy you need. And then you secrete adrenaline, noradrenaline, right? So that's what gives you that oomph. And it inhibits the bladder contraction. So in other words, You won't have to pee, no peeing, no pooping, dry mouth. Everything else is in overdrive. Okay. And then the parasympathetic, saliva starts to flow again, heartbeat slows down, the bronchi starts to constrict, peristalsis in your GI tract starts again. Your liver will release bile to help with the digestive process, and your bladder will contract. Maybe you have to pee. Okay. So that's the difference. Sympathetic, high alert, parasympathetic, chill. Okay. All right. Primary neurotransmitter that's used by the parasympathetic nervous system is acetylcholine. Here's a fun fact. Studies have shown that every time you move your body, a number of beneficial neurotransmitters like dopamine, norepinephrine, serotonin, and acetylcholine get released into your brain. And when that happens, it can decrease your feelings of anxiety and depression. Simple exercise, moving around. It's a fun fact. Let's talk more about acetylcholine. So what is acetylcholine, right? So it's a neurotransmitter. So that's a chemical that actually carries messages from your brain to your body, right, through nerve cells. It's an excitatory neurotransmitter. So in other words, it excites the nerve cells and it causes them to fire to send different messages. Acetylcholine gets its name from two substances that it's made from. Acetyl group, which is acetyl coenzyme A, which comes from glucose. And then there's a nutrient called choline. So choline is found in foods like egg yolk, soy, liver, certain seeds of vegetables, and legumes, beans. Choline is also made in your liver to a degree, small amount. And acetylcholine is involved in many, many important functions of your body. So it's the one neurotransmitter that plays a major role in voluntary muscle movement. So muscle movement that you control. Nerve cells stimulate the muscular cells and the muscle nerve cells, causing muscles to contract. Also plays an important role in brain nerve cells in processes like thinking and memory and learning. So acetylcholine is an important neurotransmitter. So acetylcholine will bind to receptors. There are two types of receptors, muscarinic and nicotinic. So we'll start with the muscarinic receptors. Muscarinic receptors, when acetylcholine binds to them, it regulates the contractions of your heart and your blood pressure, decreases your heart rate, helps food move through your GI tract. It causes glands to secrete substances like tears and saliva, milk if you're lactating, sweat, digestive juices, controls the release of urine, contracts muscles that control the nearsightedness vision, and can cause an erection. When it binds to the nicotinic receptors, it allows skeletal muscle to contract, and then it causes the release of adrenaline and norepinephrine from your adrenal glands. That's whoa, right? It activates your sympathetic system with the release of that norepinephrine. And both the muscarinic and the nicotinic receptors are involved in memory, like long-term memory, working memory, or short-term memory, formation of memory, and retrieval of memory, retrieval of ideas and thoughts that you've had, right? So those are the receptors. There are lots of disorders that can involve acetylcholine. The number one disorder, myasthenia gravis. So this is an autoimmune disorder. I call it also known as ragdoll syndrome. So just think, ragdoll. Your immune system will actually attack the acetylcholine receptors, won't let the acetylcholine bind. If it doesn't bind to the receptors, loss of muscle movement will occur, okay? No cure for myasthenia gravis. Treatment would be, suppressing the immune response and amongst other things. Alzheimer's disease, right? So that's a form of dementia that's progressive. And believe it or not, part of one of the theories of its causation is a deficiency of acetylcholine. Here's another fun fact, and pay attention to this one. Anticholinergic drugs are now believed to increase your risk of dementia. Benadryl is one, so stay away. Other diseases involving acetylcholine, Parkinson's disease. So we use anticholinergic drugs to reduce tremors and drooling that are associated symptoms of Parkinson's. And then our good old EPS, extrapyramidal side effects, things like oculogyric crises, dystonias, and other involuntary movements that are usually a side effect. That's right. you knew it, of antipsychotic meds. The antipsychotic meds block dopamine and they cause increased cholinergic activity, right? So we can use anticholinergics to treat EPS. So how do cholinesterase inhibitors work? So they work because they increase activity at the acetylcholine receptor by blocking the breakdown of acetylcholine. So the result of blocking that enzyme is that there's a buildup of acetylcholine in that synapse and continuous activation, excitatory activation of the cholinergic receptors. We use them to treat Alzheimer's disease, myasthenia gravis. In both of these conditions, there's a severe decrease in the amount of acetylcholine receptor stimulation. So the cholinesterase inhibitors like donepezil, Aricept, and ribostigmine, which is Exelon, and galantamine, which is Razidine, all increase cholinergic transmission by inhibiting cholinesterase at the synapse. And this provides sometimes some symptomatic relief for people with dementia. And then here's one that chicks usually know about, botulinum toxin, right? Botulism, Botox, right? Everybody knows Botox. It's used to treat muscle spasticity because it paralyzes the nerves. It's also used for cosmetic reasons, get rid of those wrinkles, right? And it's used to treat migraines also. And how does it work? It prevents acetylcholine release from the end of the nerve cells. Okay, so there's a fun fact. Some examples, there are lots of anticholinergic drugs. Atropine. Atropine is used typically for increasing one's heart rate. If somebody comes into the hospital to the ER where they are so bradycardic, we can actually give them an atropine IV and get their heart rate increased. And atropine ophthalmic drops are actually used orally to decrease secretions, and that's typically a hospice use. Then there's benztropine, also known as Cogentin. And that's really the primary drug that's used to treat EPS, even sometimes to prevent EPS and sometimes Parkinson's. Glycopyrrolate, which is used to treat severe drooling and usually with kids with cerebral palsy. Scopolamine, it's used for dizziness, vertigo, and nausea or vomiting. It's slow to work. Scopolamine is a little patch that goes behind the ear. It doesn't work immediately, so it's not the drug of choice anymore. Trihexyphenidyl, which is used to treat Parkinson's and EPS. Diphenhydramine, Benadryl, stops the histamine response. So when you take Benadryl, you dry up, right? Dries up the runny nose and the watery eyes. Dimenhydrinate, Dramamine, right? That you can get that over the counter. It's used for like motion sickness, nausea, vomiting, right? And then flavazate, which is for an overactive bladder. That's one of the ones. There's several different anticholinergics that are used for overactive bladders. But on the downside, they can actually stop the bladder from contracting too much, and people can wind up with urinary retention. So, so cholinergic versus an anticholinergic, right? So when the cholinergic receptors are activated, they lead responses that are produced by acetylcholine, right? So the increased secretions of the glands, smooth muscle contractions, and enhanced neuromuscular transmission. Cholinergic effects are usually associated with your parasympathetic nervous system, right? Rest, digest, rest, digest. That's your parasympathetic. So it promotes things like digestion, salivation, right? Slowing down of the heart rate. Anticholinergic drugs block the effects of acetylcholine at its receptors, leading to the opposite kinds of responses. Decreased secretions, smooth muscle relaxation, reduced neuromuscular transmission. And this is associated with your sympathetic nervous system, fight or flight, okay? And also these drugs are used to treat things like overactive bladder, motion sickness, and some respiratory conditions, okay? So you've got cholinergic drugs and anticholinergic drugs, okay? And this is just another chart that I threw in that kind of can show you as far as the drugs are concerned. Central nervous system, peripheral nervous system. And the peripheral nervous system, you have your sensory, right, which the information coming in, and then you have your motor information going out. And then from the motor, we have the autonomic, which is the automatic, and then the somatic, which is the voluntary side. So we're going to talk about the autonomic, which is the automatic side, which is sympathetic and parasympathetic. With the sympathetic nervous system, these groups of drugs, right? Alpha 1, alpha 2, beta 1, beta 2 blockers are used. And with the parasympathetic nervous system, nicotinic and muscarinic receptors are the anticholinergics that are used. Okay, so let's move on. That's awfully small, so let's see if we can't make it bigger for you folks. Oops. All right, so alpha 1 drugs, they contract smooth muscle. Okay, so they are things like pseudoephedrine, right? Treats congestion by vasoconstriction. Okay, alpha 2 drugs, vasodilators, like clonidine, used to treat hypertension, right? And then beta 1, they stimulate the heart with increased heart rate and contractility. They cause the kidneys to release renin, and that renin, angiotensin 1, angiotensin 2, aldosterone system in the kidneys, right? But that's an example of a beta 1 drug. Could be like dobutamine, which treats heart failure and increases cardiac output. That's an inotropic beta 1. Selective beta blockers they inhibit, right? So now we're blocking the beta 1. Think about your beta blockers, metoprolol, propanolol, labetalol, right? And what do? They slow the heart rate down and also decrease blood pressure, right? See how easy this is? Then you got your beta 2, right? So these are selective, beta 1, beta 2. Your beta 2 stimulators, primary relax smooth muscle, and bronchodilate. Think about albuterol, right? Albuterol, your rescue inhaler. Take a puff, boom, bronchodilate. That's the stimulation. And then the inhibition, non-selective beta blockers that block beta 1 and beta 2 receptors are things like propanolol, which is a beta blocker, but it's non-selective. And it lowers blood pressure, but it also can cause bronchoconstriction as a side effect. So one fun fact to know. Okay, and then let's talk about agonists versus antagonists. Here's the way to remember this. An agonist activates the receptors and mimics what the natural neurotransmitter that would normally bind to that receptor would do, right? So it's a drug or a substance that binds to a receptor and causes the same action as the substance that normally binds. So that's an agonist, right? A like thing. Antagonists block the receptors, preventing that natural neurotransmitter from binding and exerting its own effects. So an antagonist or a blocker binds to a cell receptor and makes it unable for the agonist to bind. And as a result, the agonist is now ineffective. Can't do anything. And your prime example of this would be any kind of opioid and naloxone, Narcan, right? We'll talk more about this in a second. We're going to talk now about the different types of receptors. So the nicotine receptor agonist, the nicotinic, stimulates nicotinic acetylcholine receptors, and it mimics the effect of acetylcholine. So what would be an example of this? Nicotine gum, nicotine patch, nicotine lozenge, right? It's an agonist, so it goes where actual nicotine would go, to those receptors, right? And then you slowly wean yourself off of it and you can quit smoking, they say, right? So that's an agonist. It's a nicotine receptor agonist. So the nicotine gum, patch, whatever, attaches to those receptors, the nicotinic receptors, and does the same thing as nicotine would do when you're smoking a cigarette, okay? So other nicotinic agents here, the nicotinic patch, which we talked about already, but you want to make sure that things like allergic reactions, irregular heart rate, palpitations, and symptoms of nicotine overdose. And yes, you can overdose on nicotine, which are nausea, vomiting, dizziness, weakness, and a rapid heart rate. Okay. You have to be careful with nicotine patches and nicotine gum. Use cautiously in people that have any kind of cardiac issues. Don't use in somebody that's had an MI, any serious arrhythmias, CAD, angina, right, or vasospastic disorders. If they're taking antidepressants, MAOIs, you have to lower the dosage because they can cause harm, and also not to be taken when pregnant because they can harm the baby, the fetus. So that was the nicotinic. Now we have the muscarinic. Muscarinic agonists stimulate the muscarinic acetylcholine receptors, which leads to increased parasympathetic activity. They're used for things like improving bladder function, in other words, overactive bladder, bethanechol, or they treat glaucoma, pilocarpine, okay? Pilocarpine stimulates the muscarinic receptors and it contracts the ciliary muscle. This action lets the aqueous humor drain from the anterior chamber of the eye and it reduces the intraocular pressure. See how easy that was? And remember, whenever you're administering pilocarpine, pressure on the lacrimal sac right here for at least a minute to 2 minutes after instilling the drops to minimize systemic side effects, okay? Tell your patient not to drive at night because they can have a lot of blurry vision. And there's also a possibility of hypotension as a side effect, okay? Muscarinic antagonist, right? The opposite, atropine. Atropine is a drug that's a specific anticholinergic responsive type drug, and depending on the dose is what it will do. It's used for bradycardia. It's used in hospice and also sometimes preoperatively, orally, to decrease secretions. It will dry the mouth out. And believe it or not, it's used to treat certain insecticide and mushroom poisoning cases. You have to make sure that the patient knows that it'll cause dizziness, dry mouth, drowsiness, urinary retention. Never give an anticholinergic to somebody with BPH because you'll make that benign prostatic hypertrophy. You'll make them retain urine even more. Okay, so anticholinergics are a no-no for people with BPH. Alpha-1 agonists and antagonists, right? They basically they're a subtype that kind of they influence smooth muscle and blood vessels and the prostate gland, right? Okay, so here we go. Let's look at some alpha-1 agonists. Pseudoephedrine and phenylephrine. Pseudoephedrine now, you can't even buy it at the store. If you go to the drugstore to get it, it's kept in the pharmacy. You have to show your driver's license, and they limit the amount because people use it to make methamphetamine. So most of the over-the-counter decongestants now have phenylephrine as opposed to pseudoephedrine, okay? But pseudoephedrine and phenylephrine basically do the same thing. They cause constriction of blood vessels and shrinkage of the nasal mucous membranes, increases airway patency, decreases nasal congestion, right? Used for allergies, head colds, that kind of thing. However, remember, can elevate your blood pressure. Don't give it to patients with glaucoma, hypertension, BPH. Monitor their blood pressure, can make them nervous, cause insomnia, and never give these drugs right within 2 hours or so before bedtime because it'll keep them awake. Alpha-1 antagonists, tamsulosin, terazosin. That is a very commonly used drug to treat BPH, and the symptoms of BPH are usually urgency, frequency, and dysuria. Can't give it with ketoconazole. Don't give it to pregnant people, which you wouldn't do anyway. Be careful with older adults and those with renal insufficiency. Complications, hypotension, especially orthostasis. After the first dose, monitor their blood pressure. And just be very careful as far as the side effects, right? Alpha-2 agonists and antagonists, right? So alpha-2 agonists stimulate the receptors, leading to a decreased sympathetic outflow, reduction of blood pressure. Alpha-2 antagonists block the alpha-2 adrenergic receptors, increasing sympathetic activity, right? So clonidine, also known as catapress, alpha-2 agonist, used for hypertensive crises and hypertension. I'm not a big fan. Problem with clonidine is it can cause rebound hypertension. You should not give it to people that are on anticoagulants, that have any kind of hepatic failure, if they have liver problems, and anybody that's on an MAOI, and breastfeeding women, right? They can gain weight. They can start developing edema with the long-term use of clonidine. Rebound hypertension, like I said, is a problem with clonidine. And because it's an alpha-2 agonist, so it mimics the effects of what normally would attach to that receptor, the patient can have as a side effect something that looks like EPS, involuntary jerky movements, dizziness, rash and yellowing of the skin. Yellowing of the skin would be secondary to liver problems, right? Alpha-2 antagonists, they're not very common. They're used in managing side effects of the alpha-2 agonists and things like erectile dysfunction, right? So your Viagra, your Cialis, okay? And then your alpha and beta receptor agonists. You got catecholamines, right? Like epinephrine, norepinephrine, and dopamine. Epinephrine and norepinephrine are adrenergics that stimulate the receptors. Dopamine basically works on the kidneys, the heart, and the brain. Dopamine is directly related to a lot of things like dementias, depression, Parkinson's disease, okay? So alpha and beta receptor agonists. Epinephrine, right? When do we give epi? Think about an EpiPen. So usually we'll give it IV, can be given sub-Q, can be given IM, can even be inhaled. It decreases vasodilation and increases vascular permeability. So in other words, if you're having an allergic response, everything's starting to swell up, it will cause everything to relax, right? Used for severe allergic reactions. It only lasts 15 or 20 minutes. Quick in, quick out, right? Don't give it to anybody with narrow angle glaucoma. Be careful with people with cardiovascular disease. Always be careful with the elderly. And always monitor their vital signs when you're giving it IV. It can be a little dangerous. And then dopamine. Dopamine clinically is used to treat shock, to increase organ perfusion, cardiac output, and correct hypotension. So somebody is in the hospital, that they're in either hypovolemic shock or cardiogenic shock. We can actually administer an IV drip of dopamine, and dopamine will kind of improve the blood flow to all their organs, increase the cardiac output, get their blood pressure up a little bit. So it's good as a treatment for shock. Always check their blood pressure while they're on it. You're going to monitor their cardiac output, their urine output. If their urine flow decreases, you may have to decrease their dose of dopamine because it can be too much, where it's causing too much urinary retention. And adverse effects, side effects can be hypotension, tachycardia, palpitations, and decreased blood flow to the extremities, because it's taking the blood flow, giving them to the organs, giving the blood flow to the organs, and not so much to the extremities. If the patient has unusual sudden onset of sweating, dizziness, palpitations, or chest pain, get the doctor. Okay. Then there's something called cholinergic syndrome. So if a patient's on cholinergic drugs, you can remember the symptoms by remembering slodge, secretions, excessive secretions, bleh, right? With salivation, lacrimation, tears, urination, defecation. So you're just crying and spitting, drooling and peeing and pooping, gastric cramping, emesis, you're vomiting, meiosis, and blurred vision. Okay, sludge M. So if you remember sludge M, secretions, lacrimation, urination, defecation, gastric cramping, emesis, meiosis, and blurred vision. Boom. Okay. So that was the best I can do with these, autonomic nervous system drugs. If you have any questions, you know where to reach me. And please shoot me a text or an email and let me know what topics you want me to cover, because I am back. I'm going to start doing NCLEX prep as well. So good to see everybody. All right, take care and bye for now.